You're all welcome to this webinar. This webinar is COVID-19 community transmission facing Nigeria, assessing the risk we all face. Just give a brief introduction of the panelists and the speakers, and then we can immediately proceed into the individual presentations. We have Dr. Amina Baloni. She's the Honorable Commissioner for Health for Kaduna State. She's joining us from Kaduna. You're welcome, Dr. Amina Baloni. We also have Dr. Akim Lawal. He's one of the lead speakers on this webinar. Dr. Akim Lawal is a consultant chemical pathologist working with the National Hospital here in Abuja. We also have Dr. Newa Medugu. She's a consultant microbiologist with the National Hospital as well. She's also joining us as a speaker. And lastly, we have Dr. Salamut Belgore. She is a community public health physician at the University Zaria Teaching Hospital. So you're all welcome. So very, very quickly, we'll proceed to Dr. Akim Lawal. Could you give us a brief presentation as an introduction into this webinar? Thank you very much.
Okay, thank you very much. Actually, I'm the second speaker, but I'll be giving a small introduction, and let me quickly get on with that. This is where I work, all the logos and all that. I'll come back to that. But okay, so we took some what do you call it? We did some statistics, you know, the responses by country, those that are watching us, and we discovered that, well, we may not want to look at this because some people just left the US there, but we saw Kenya and UK, well, right? People that joined us, and we looked at the towns, those that responded, and it looks from Abuja to Gombe to Safi and Zaria, Maiduguri, and all that. Okay. Of course, well, I don't know, the male will always beat the females, so I don't know. Maybe I may have some gender bias here. And we're also surprised that soldiers, well, we noticed that medical practitioners, many of the people that responded, most of those joining us, even though they know much more about COVID, they seem to, I mean, the question seems to have sort of spawned their interests. We have cinematographers and all that. And these questions were not, they were just trying to see how, they were not intended to find, we're just trying to see, they're just basic questions. And we found out that like half of people think that what they read on social media has conflicted their views. You hear this today, you hear that tomorrow. It was also interesting to find out that many people that responded were willing to have a test or test their subjects against COVID-19 infection. You know, we have, whether we like it or not, some of us have house workers, people coming to our house on a long-term basis, some live with us and all that. And we may want, I mean, some people just think they can test all that. Most of us make contact, we go to the market, we worship. But these were the responses from those questions. And okay, this were the, do you have close family contact with domestic workers living outside your home? That's those that live in the, maybe in the outskirts and come to your home. So like, we can say like more than half. There's this thing about you wearing lemon, ginger, and all that. I think a lot of people are taking these multivitamins and some drugs to prevent COVID-19. We'll talk around this. We want to make this presentation to be as basic as possible because we want to have a kind of community engagement. I'm happy a lot of us think that school children can be, are at risk. Almost 90% of responders of COVID-19, and maybe that's why they're still around. And, at times you look left, right, and center, you wonder whether the COVID-19 is just a conspiracy. And so people, 25%, think so. Well, some don't really know. And we should be worried about this 25% and those that don't know, really. I'm not going to go into this. During the question and answer, we can look at the questions a lot of people threw at us. These are the questions that when they were registering, they registered. I think Dr. Giwa will do justice with that.
Thank you, Dr. Meidogo. So you have the floor. You have over 10 minutes. We're all anxious to have your presentation. Please proceed.
Thank you very much for having me. I'm excited that we've been having a lot of discussions around the medical practitioners, but this time around, we're trying to reach the actual community. And as we know, community transmission has started in Nigeria, and we're actually increasing exponentially. So this is a very important issue to discuss at this point. So this is what the graph for Nigeria looks like in this month. And look at the total number of daily cases receiving treatment. So we're on the upward trend when it comes to that. The daily number of confirmed cases is also going up. So we're yet to even reach the peak when it comes to coronavirus. And look at what has happened in the past 14 days. Every day we have an increase. So people, in fact, last week, 2 people did ask me that, when is the second wave coming? And I'm like, we haven't peaked in the first wave, so there's no even talk of a second wave right now. As far as I'm concerned, we only saw a bit of coronavirus, and coronavirus is really coming to town now. And this is the time that we should take it much more seriously than we were taking it before. So 2 months ago, everyone was really scared of coronavirus. And that was when we had just a few cases. Now we have so many cases, so many deaths, and everyone is, I would say, nonchalant about it. And so unfortunately, we're having more deaths as the days go by. It's really unfortunate because in the health sector, I know how painful it is when you walk across the world and people are shouting and crying. It's really, really painful. And I was listening to the PTF yesterday, and he said, Boss Mustafa said something. He said healthcare workers are no longer at the front line. And I really agree, because at this stage, the front line, the people that should prevent themselves from getting infection. It is when they get these infections that we healthcare workers can do something about it. But we have only so many hospitals, only so many doctors that are there to fight for the nation as it is. So safety and prevention is really key to preventing coronavirus. So what is this coronavirus? So corona just means crown. We've all seen it several times. It's a virus that has a crown, but then it's a fragile virus because it is covered with oil, which it gets from the human cells. It's just called corona because of the crown-like activity, crown-like appearance. So first reported in Wuhan. That doesn't mean it started in Wuhan, China. It was just first reported there. There's still a lot of speculation as to where this virus emanated from. So it has many sisters and brothers. The MERS is one, the initial SARS is one, and the common cold that we have, at least 4 different coronaviruses are cause of common cold. How do we get this coronavirus infection? Essentially, when an infected person coughs or sneezes, and that cough or sneeze can get directly into our face. We breathe it in and it goes into our respiratory system, or it may just land on a surface and then our hands go on the surface, and then we take our hands to our eyes, our nose, and our mouth. So that is one of the most common means of transmission for COVID. Now, there are other means of transmission that have been documented, but not as important. One is feces, another one is blood, and then also urine. But common things occur commonly, so respiratory droplets are the most common means. So let's note that it is not airborne. There's a difference between transmitting something by coughing, right? So that cough usually what you release from coughing can only go about 2 meters, or currently we say 2.64 meters for COVID. But when we say something is airborne, it can go as far as 80 meters, for example. So that is why keeping a distance of 2 meters or 2.5 meters should be sufficient, in addition to other things that we do to prevent us from getting COVID. A common concern that I hear every day, and this is among security men that I come across, among policemen, is that wearing this mask may cause too much carbon dioxide to accumulate. So they bring it down below their nose. But then that is really dangerous, because the nose can also lead to transmission of the virus. So we say, okay, you are concerned about carbon dioxide accumulating. If it is accumulating, then your mask will be like a balloon. But it's not accumulating because it's leaving, right? And fresh air is coming in. So there's no danger of carbon dioxide intoxication or oxygen deficiency. However, in children, what we're afraid of is strangulation. You can imagine a 3-year-old wearing a mask and then it gets tangled around the neck. That child doesn't have the ability to help him or herself. So that is where we have concerns, and not really carbon dioxide intoxication or even oxygen deficiency, as the case may be. However, there are instances where you do not have to wear a mask. For example, when you're jogging, you're exercising, and you are not close to anybody. Why is that? It's because it reduces your ability to breathe comfortably. You're doing something really strenuous. And once your mask is wet, it makes it really difficult to breathe, and also promotes the growth of microorganisms. Lots of bacteria can grow in there, so you can get infection. So during exercise, exercise is good, of course. You're allowed to practice physical distancing while not wearing a mask. The issues of shoes has really come into play. So shoes generally are not considered to be infectious when it comes to SARS-CoV-2. However, remember that some families have children that crawl on the floors. So those children, if perchance there's SARS-CoV-2 on the shoes and it gets on the floors, will have it all over their hands. And then, of course, you know, kids, where does it go to next? The mouth, the nose, and the eyes. And then it becomes a problem. So as a precautionary measure, we should keep our shoes outside when we come in. I think this particular issue of alcohol gained a lot of popularity over time. I think there was this particular country that was even sharing alcohol in their SARS-CoV-2 packs that they were given. So they were giving gloves, hand sanitizers, and a bottle of alcohol, because they said, oh, if alcohol can kill the coronavirus on my hands, then it can kill the one in my body, right? So lots of people did get drunk. However, excessive alcohol is really dangerous, and it did cause quite a number of deaths from driving accidents in that particular country. And of course, if you're diabetic or have other health conditions, it can be really risky. So alcohol, no, it doesn't have any role to play when it comes to preventing yourself from getting coronavirus. But this is the one that it's not dangerous. It says that if you drink lots of pepper soup, you will not have coronavirus, or if you have the coronavirus, then it will cure the coronavirus. Well, fine and good. If you like pepper, you're a person, please feel free. It's good because you get your nutrients, you get fluid, which is balanced in salts and other things and minerals. So it's great, but know that you are only improving your nutritional status. When it comes to coronavirus, it has no role to play. And the role on how to prevent coronavirus is essentially what I've mentioned before. Preventing yourself from getting the infection by wearing a mask, washing your hands frequently, and of course, keeping a safe distance. So people are really concerned that can houseflies, for example, transmit coronavirus? So if you look at it, practically speaking, if somebody should cough on a table, a housefly should land on it, and then the housefly moves somewhere else and lands on it, and then you touch. But practically speaking, it's possible. But so far, current research has shown that houseflies do not transmit COVID. But let's all remember that COVID is really new. So a lot of information are coming. If you remember around February when it first came, people were like, no need to wear mask, no need to wear mask. And all of a sudden, well, you may wear mask. Now you must wear mask. So as information comes, new information comes, things might change, and we may see houseflies to transmit. For now, they're not the culprits. So yeah, I think somebody became famous by telling people to drink bleach or disinfectants. Please, that it's poison. Don't do that. Only use that to clean your surfaces. And even at that, use the dilute one, not the concentrated one. It can really cause irritation, can cause blindness, it can cause burns on the skin. So a no-go area. Even ethanol, some people have gone as far as drinking concentrated ethanol. And of course, what happens? Gastritis, and then the stomach bursts. Before you know it, the patient is in hospital, bleeding internally. So it's a no-go area. Try to keep safe and don't ingest these harmful substances. There was this study that was very, very detailed around March, and it gave all the reasons under the earth why coronavirus cannot survive in Africa. And guess what? It did come, and it's wreaking havoc in Africa. It was like, okay, because of the sunlight, the virus is fragile, it cannot live above that 56 degrees centigrade, and therefore we won't get it. But we know what has happened. So when it finally came to Lagos, people in my town of Maiduguri were like, Maiduguri is too hot. Corona can't come to Maiduguri. But guess what? It's in Maiduguri also. So all those people cooking themselves in the sun, thinking that they're curing coronavirus. In fact, I have women using hair dryers on their noses because they think it will kill the coronavirus. It's highly unsafe. Please don't do that. Ginger and garlic and lime are all good, right? They're all good. But the problem I and other healthcare practitioners have with this is that you load yourself with ginger, garlic, and lime, and you think you are safe. So it gives you this kind of false sense of security. You go into the community, you are not wearing your mask properly, you don't wash your hands properly, and you don't keep safe distance, all because you are thinking you're taking the magic concoction of ginger, garlic, and lemon. They are not a cure for COVID. It's good for your body, but they have nothing or almost nothing to do with COVID. So spreading disinformation is key. Let everybody take ownership of their own protection. We're only as strong as the weakest link in the society. So if we have a group of people that do not believe that there is COVID and they're going around doing stuff that they like, that is how the community is, right? As a whole, we help to protect each other. So no matter how hard it is, try to convince them that, oh yes, we know that you say you have strong genes, you won't catch COVID, but I can catch COVID. So because of me, please do this and that. And let's all keep ourselves safe. I got this question last week and also yesterday. Really, most people that have COVID will recover. And that is why I guess there were stories that Nigeria doesn't have COVID, it's all a scam. 90% will be fine. In fact, over 90% will be fine. But then remember that there are hundreds of thousands that are still within that 10% that can die from the disease. So we just need to be careful. And keeping safe distance is really possible. Even in villages in India, people have been able to keep safe distance among themselves. It is key and it is important. One person asked this question that why are some people not showing any symptoms of COVID? They test and they're positive, but they don't have a symptom. Well, that happens to many diseases. Malaria, for example, you can go for a malaria test and it's 1+, but you're not showing any sign. That doesn't mean you don't have malaria. So there are 3 categories of people when it comes to COVID. Those are asymptomatic, right? They don't have to show any symptoms. They're the ones that come and dance and say COVID is fake and all that. And then there are those that are pre-symptomatic. You've tested, but just give yourself 7 days. You will have some symptoms. Then there are those that think they're asymptomatic, but they're symptomatic, just that they're presenting with unusual symptoms. For example, diarrhea. You say, oh, they tested me for COVID, don't mind them, all I had was diarrhea. But then diarrhea is one of the unusual presentations of COVID. These days, we're even having delirium as a presentation of COVID. So when we say it's asymptomatic, we should be careful what we mean by asymptomatic. And also, people are confused. Lots of literature, hydroxychloroquine works, no, it doesn't work. This works, no, this works, no, it doesn't work. We should understand that because it is a very fast evolving field, it is natural to have these kinds of research. So in the end, by the time you have, let's say, 1,000 research works, you can combine them and filter and see what makes sense. But it's natural at this stage to get conflicting information, really. And this question particularly touched my heart. And I remember that the wife of the Kaduna State governor demonstrated it on her Instagram handle, how to wash your hands when you don't have soap. And she used ash. And interestingly, I researched, and yes, countries have used ash to wash hands with some degree of effectiveness. But of course, this is when push comes to shove. So does COVID-19 confer permanent immunity? Nobody knows now. It just started in December. So until we have 1 year or 2 years from now, we really cannot answer that question. So those that have recovered from COVID still need to keep safe and wear their mask and do everything because we don't know if they can get it again. I love this question. When do you think the pandemic will end? Algorithms have been drawn. It is said that it will probably last 2 years before we even attempt to see an end to this pandemic. It's also tied to the availability of a vaccine, if there ever will be a vaccine. So we know that SARS, MERS, and the other coronaviruses, there has been no successful vaccine against any of them so far. So if we're lucky and we get a vaccine for this, then it could be shorter than 2 years. But if it goes the way of its other brothers and sisters, there may not be a vaccine. Essentially, I would like us to remember to keep safe and do all it takes. Wear your mask, then as often as you can. Now, the best form of mask, of course, is your N95 mask. It is very expensive, 7,000 or 10,000, depending. But then again, you have your medical mask, which is also protective, but it's also expensive and it yields lots of waste. But even your cloth mask has been proven to be effective. So if I wear a mask, you wear a mask, everybody wears a mask, then the chances of transmission in the community decreases quite a lot. The best is the N95, but the cloth mask is also very key and it does protect. So as a community, stay at home. The lockdown was lifted by the PTF, not because we have, you know, a lot of countries will say, okay, we have reached a plateau, we have reached a peak, we're going down, then we open. In this case, it wasn't like that. It was just a deal with that the country was in between the devil and the deep blue sea. It's either coronavirus kills me or hunger kills me. And then it was decided at the upper levels that we should weigh these things and try and make sure that people take responsibility. So if you don't have to go out, you don't have to go out. Do stay at home. The churches and the mosques are open. Nobody is forcing you to go. Avoid these crowded places, except if you have to go, even including the market. Wherever you go, all these places, please do keep your distance. And then hand hygiene cannot be overemphasized. So thank you very much. Please stay safe and keep everybody safe. Thank you.
Dr. Medugo, thank you so much, Dr. Medugo. A very interesting presentation. I think I was able to learn a few things. I typically will think that a housefly could transmit. If we say by contact, you know, you could touch, you know, surfaces and you could transmit the coronavirus infection, then it's, you know, the thinking will also be that, you know, easily flies also move from surface to surface, and they can easily transmit the virus. Thank you for that clarification. But I think most importantly, what I got out of your presentation is the fact that, yes, not everybody is going to be infected. And if we are infected, not everybody is going to come down with the clinical, will fall sick from the COVID-19. And so we're looking at this roughly, I mean, from your presentation, about 10%. But 10% might seem small. In a population of 170 million Nigerians, 10% is about 17 million. So I think that's a significant number, you know, if we look at it. Again, a lot of these cases are not effectively tracked, and they're still not properly reported. So I think, again, the key message here is that we continue to wear our mask, which is one of the most effective means of protecting ourselves, as well as keeping distance, safe distance amongst crowded population. Thank you very much, Dr. Medugo, for your presentations. There are a couple of questions that will come afterwards, but for now, we'll take the next presentation. Dr. Akim, are you with us?
Okay, thank you very much, Dr. Giwa. Yes, so I'm a chemical pathologist, and at times the language I speak is very hard to break down, but I will try as much as possible. A lot of people have been worried about the testing. Why are we not testing? So why are we, the numbers, how real are they? Some even don't believe the numbers, like those that don't believe COVID exists. But let me just quickly make us understand that there are 3 types of ways to diagnose COVID-19. The molecular tests, which the NCDC is doing, and it just means that they would obtain sample from the nose, you know, and try to, so the target here is the RNA. That's the first one. It's very sensitive and specific, but it's actually very expensive. But government is not charging a dime, any couple for it, and maybe that's why. So the resources are not easy to get by. The WHO, the CDC, Africa CDC, NCDC, everybody, you know, they're trying to manage the procurement process such that it's available and it is. So they are doing what you call smart testing. It's also a bit delicate because the labs must be is highly phosphated labs, because it's a very highly infectious particle the virus is, and so it could if we are not careful, the people doing the test may become infected and all that. Secondly, the antigen tests are also available. The viruses produces antigens, you know, and the antigens can be specific to that virus. And some tests target those antigens. So when you find those antigens, you will say, okay, this person has COVID-19, but they are not very common. But the antibody test is actually interesting, and that's the one that may it's of course, in terms of the affordability, is not as expensive. It's widespread, but it has its own limitations. It can be sensitive and specific. However, there's this drawback. If you look at what my arrow is, you find out that it takes like 7 days, minimum of 7 days for it to become positive, because the body, antibodies are what the body's response to any infection. And okay, this slide was credited to Professor Rosanna Appealing of the London School of Tropical Medicine and Hygiene. If you see here, okay, so this is how you take sample for the nasopharynx or the aura, and you for the molecular test. But you can use blood for the antibody test. I won't talk much about the antibody test because it's not very common. But okay, so let's look at this slide, and I'll try as much as possible to be as elementary as possible. Okay, so if we look here, people need to understand that there's a lot of fear. For instance, maybe they sat with somebody, and the next thing they heard that the person was positive for COVID-19, and they start panicking. You don't just develop the infection immediately. So there's some time lag between when you have symptoms or you have the infection. There's it could vary. This slide is actually talking to viral infections and immune response generally, but you can follow through. It takes between 2 and 14 days for the infection to develop really. And if you look at this graph, this RNA is just representing that the virus, that's the COVID, the SARS-CoV-2, or what you call that causes COVID-19. The RNA, that is the genetic material, starts to rise just about, say, between day 2 to day 14. And it has to what? It has to come down as the body takes care of it by producing what you call antibodies. Okay, so if we choose to run a molecular test and you come and the person started the symptoms, and between day 0 when the person started the symptoms and day 7, there's a high possibility that you pick the person as being positive. But if 7 days have lapsed, between 7 and 14 days, the chances get to about 50%, meaning that somebody could have COVID-19. You run the NCDC molecular test, and the person is said to be negative. You just have to know that there's the chance. These are the chances and the probabilities. That person may be having the infection. Doesn't mean that the person doesn't have the infection. Depends on the target of the test. So there is the antigen test to follow the same dynamics. The antibody test on its own, yes, it has a drawback, and it takes like 7 days post symptoms for it to start to rise. There's something you call the IgM and the IgG. The IgM is actually for any new infection, any new virus. IgM starts to, the body starts to produce what we call IgM, and also later followed by IgG. Some tests try to discover whether this IgM is there, and you can actually use it to suspect. But for now, it's only being used for what you call surveillance. For you to actually say somebody is a case and you have to isolate and do the needful, it must be a molecular test. But look at something here. If in some negative molecular tests, with somebody having symptoms especially, they may still go ahead and do what you call an antibody test and find out that there's a rise. And a 4-fold rise can actually give it a definitive diagnosis. So that's all about this slide. Like I said, you just look at the markings, but I think it should be simple enough. So the antibody tests are there. They are available and all that, but there are also issues around it. There's the good, the bad, and the ugly. So somebody may be telling you, "Oh, I have a test to do. I have a test for you. You can do COVID-19," and they give you a report. How do you scrutinize? Are you sure? Who is the facility offering it? Who is the person giving you this test and all that? So I'm not going to go through this because of time. Where they are being used for surveillance. A lot of people that are supposed to enter, they're supposed to have surgeries. They're supposed to have procedures. You find out that you go to a hospital and they find a way of delaying the surgery or even turning you back. You may not know. It's because of the COVID-19. What do you call it? Should I say environment? The red signal. Everybody is afraid and all that. And a lot of people may not have the COVID-19, but there is no the tool to survey that person is not easily available. And the NCDC have their criteria for you. For you to get tested and for you to receive treatment for COVID-19. And luckily, a global body that I also looked at the fact that COVID-19 has brought up a lot of diagnostics tests, molecular, antigen or antibody, they've kind of, and so a lot of people are going through production of this thing. So they are just trying to assess. So they call themselves find. They are online. So they have to evaluate all these tests so that they can report on them. So they're like a third party quality assessor. So that people that want to go into, I mean, I'm talking about the professionals now, doctors that have hospitals, and healthcare workers and all that, so that you know the kind of kit you say you are buying, whatever claims they are, if there's a third-party quality assessor that has given you an objective claim, you can be well advised. And also, people, countries are supposed to do their own in-country validation. So in their website, you find out that these antibody-based kits, some of them are listed from USA, and all that. So it's available. But it's also interesting, though. I think I need to explain this particular slide. So I was talking about the IgM and the IgG, where it's a bit technical too. Dr. Giwa will agree with me. But the gold standard is what you call the PCR, you know. So you find out that a total of 42 people were tested in this particular performance characteristics, and those 42 were positive for PCR, and the antibody test for IgM was able to pick 42 of them, and 2 were falsely negative. That gives you a sensitivity of 95.5%. So what we're saying is that for every test, even the molecular that I talked about, that depending on the time that you do the test, for the antibody test too, they are not 100%. Yes, specificity means that, okay, it picks 102 people were tested negative. The ones tested by antibody kits too were 102, meaning 100% specificity. So the agreement is like 98.6% for the IgM. For the IgG, you can also see the results here, 100% sensitivity and 98% specificity. These are the characteristics we try to use to assess some of these test kits that we use, so that we can give you can give clinicians confidence and also tell them some of the merits and demerits. Now, I felt I've seen a lot of people also ask about, these rapid test kits. The interpretation should be done with caution. Yes, because if you run an antibody test and the IgM is negative and the IgG is also negative and there are no symptoms, okay, so patient may not be having COVID-19 and you may not need to go for a molecular test if you are using these particular kits, But if there are symptoms, is negative IgM and IgG, there are symptoms, the patient may be in what you call the window period. I'm sure that HIV has made us to understand the window period, meaning that you should go for your molecular test, okay? But look at the red flag here. If you have IgM positive and IgG positive, it tells you that this infection just started and is deep-seated, and this patient is infective and it can spread. However, you still need to go to molecular tests so that they can enter, the what do you call it, the treatment data, and they can be offered treatment in the government facilities. Because right now, private facilities are not treating COVID, if you agree with me. You can also have an IgM positive while IgG is negative. It's also a red signal. This patient has active COVID-19 and confirmation is needed. It just means that the IgM, that means you are picking the patient early. So it's even good, so that you can really quickly request for the molecular test and the patient can receive treatment. Yes, people have also asked, and there are a lot of people, 80% of people around may have even come in contact with the virus. They didn't have any symptoms and they have recovered without even knowing it. If you run a rapid screen and IgM is, okay, sorry about that, and IgM is negative and IgG is positive, it could indicate that you are in recovery, though you may not really rule out the disease because you need to further ask the symptoms. But most likely, if there are no symptoms and there are no, person may have recovered, and that way you may know that you may have had this COVID without even knowing, and you have some antibodies. But we need to be careful here because people ask, can you be immune? Immunity is not about that you cannot be reinfected. If you had COVID-19 and you recover, like those that were been discharged, they can be reinfected. It's only that hopefully the infection will be milder because the body will have been primed. Because it has come across the virus before, the body will have been primed that there will be a faster response and the person may not succumb to it. But we need to understand what kills people in COVID-19. It's a new virus. the body doesn't understand it. Like the way I was describing on the TV show. It's like when Boko Haram attacked Abuja, and the security forces, don't know how to deal with it. Went about bombarding, and they could end up destroying many parts, many organs of the body. Then and this could actually, and for instance, there could be over response, over inflammation of the lungs, and some people will not be able to breathe and die from it. Some people may have diabetes, some people may have renal failure, and those should be wary of infection with COVID-19. So regarding diagnostics, which I may be able to break it down in the Q&A, but in the hierarchy, the molecular tests come first. But if you look at the triangle, they are expensive. Yeah, the resources are not easily available. America has tested millions of people, but others are dragging. But then, we are also doing what you call smart testing, and we are getting some headway. I cannot talk about our own graph, because if we had our way and we're testing as much as we could, then we can really talk about graph, whether we are flattened it, whether we are longer. But as of yesterday, if you agree with me, that was the highest single daily reported case. I can't remember the exact figure, but I think it was more than 700 cases reported yesterday. Antibody tests are there, but they have their own limitations, and you need expertise. You need you need consultation. You don't just walk into anywhere and say you want to do a test and they report to you. So you have to be careful there. COVID-19 is a race against time. Eventually, I'm not a prophet of doom, but we need to be very careful. Our children, they cannot stay home forever. We go to the market, we go everywhere. You saw this survey. We will get a chance to look at the survey and ask some of these questions and talk around it. But we all need to be careful. All the things we are hearing about pepper soup, things we are hearing about ginger. Well, I'm a medical doctor. There's no scientific basis. The chloroquine people are hoarding, and people are now going to hoard the dexamethasone and all those things. That is not the way to go. Let the medical experts help you. Keep to the safe distancing when you go to the mosque, when you go to church. Wear your mask, wear it correctly, not on your chin. Give you at least 2 meters gap. Cough into your elbow, and all the things they are saying. COVID-19 is real. If you have, and like I said, it's a race against time. If you believe that it doesn't exist or it's a conspiracy, until somebody near you gets it, a family member, before you actually understand, why you should not see it as a conspiracy. My short key message is, it's coming from the on that. It's just to say that the pandemic has thrown a lot of, it has presented novel challenges to the healthcare system. I can tell you, I'm happy the commissioner is with us. She will be able to tell us what Kaduna has done, what they are doing. And their states, I think I'm happy about their response so far. Molecular tests are a gold standard. Well, so particular state, I don't know how far, I don't want to mention the states. I went to go and purchase some test kits, and they said they don't have COVID in their states. And they were dragging in and the test kit, I don't understand why out of everybody you do, you are all negative, and we know that a lot of people have been presenting in the hospitals. So they didn't have professional expertise. They didn't go about it the right way. But I think we should all be wary. Antibody tests may be important in detecting infections, people with few or no symptoms, past infections, or can be used to survey people, and they can also access care instead of just rejecting them. Thank you very much, Dr. Giwa and everybody. I believe the Q&A session would
Thank you very much,
help us further.
Thank you very much, Dr. Hakim. Your presentation was very apt, and I think it addressed a number of issues around, gave clarity around some of the issues or misconception people have around the testing. But I think in summary, basically you've identified the different testing methods available. You've also cautioned the use of the rapid test kits, particularly around the interpretation of the outcomes of those test kits. I think it requires, from my understanding, I think it will require a little bit more professional interpretation for us to arrive at a more conclusive diagnosis of that test. Thank you very much. I think there are a couple of questions that will come during the Q&A session. But then I think we also have a very interesting presentation. So for the audience, I think it's important that you understand that we're trying to provide a context for the Q&A and also to allow for robust discussion. Dr. Salamatu Belgore is going to give us a brief presentation.
Good afternoon, everyone, the panelists, Honorable Commissioner. Introducing the coronavirus, they are viruses. The coronaviruses are a large family of viruses. They can cause illnesses in animals or humans. So we need to know that they can also cause illnesses in animals, not just humans. And like the first presenter said, they have we have the group of sisters and brothers like the MERS and the severe acute respiratory syndrome. So the symptoms can vary from common cold to more severe symptoms like SARS. The most recently discovered coronavirus is the COVID-19, which we are talking about now. What do we mean when we say community spread? When the outbreak started, before it was declared a pandemic, we had the most important thing that you would want to look for in a patient was the history of travel. So usually most of our first few cases had a positive history of travel from a country or an area that had the pandemic going on or the outbreak going on. So, but with time, we started recording cases from patients that did not have any history of travel. So that would mean that the virus is spreading from one person to another person within our community. So that's what we mean by community spread. Cases of COVID-19, we have classification based on the clinical, epidemiological, and laboratory findings. We can have suspected cases, we can have probable cases, and we have confirmed cases. So, but suspected cases must have been had a history of exposure to somebody that is infected, or to somebody that is any person, including severely ill clients, presenting with symptoms and who within 14 days before the onset had any of the following exposures. So that's a suspected case. We also have a probable case, and we have a confirmed case. The confirmed case is the one that is laboratory, has been confirmed by laboratory tests. So who is the contact? A contact is a person who has had any of the following exposures within 2 days before and 14 days after the onset of symptoms, after the onset of probable or confirmed case. So we need to be able to know this fact, so that we understand why we need to observe the preventive measures that are told to us by the populace to observe, and which includes if you make face-to-face contact with a probable or confirmed case for more than 15 minutes, you can get the virus. But it's also been documented that even for less than 1 minute, it's possible, because a lot of information is still and research is still ongoing about this novel virus. So we can never say never to some of the details or the facts. So we also have direct physical contact with a probable case, and direct care for a client with a probable or confirmed COVID-19 without using the proper PPEs. So how do we stop community spread of COVID-19? One of the most important ways to stop it is social distancing. And that was the reason for the lockdown in the first place. So social distancing, if we don't need to go out, please let's stay home. And if you need to go out, let's avoid mass gatherings or crowded places. And then even when we go to places like the malls or go to the marketplaces, let's observe social distancing, wearing of face mask, and hand wash as frequent as possible. And these things have to be done the proper way, not the face mask one or the chin. And then the hand wash properly done, not just within a second or 1 minute you say you have done a hand wash. So the government, we also need to have increased testing capacity, provision of adequate supply of PPE to the health workers, and then provision of social and medical support to vulnerable groups, which are all ongoing. but resources are always limited. So the public health measures that have been outlined for prevention, for us to carry out to prevent ourselves from contacting the virus is the hand hygiene, respiratory etiquette. You don't cough or sneeze onto your palm, but we cough and sneeze in the inner part of our elbows. Wear our face masks appropriately. Isolation and treatment of ill individuals, travel health advice, environmental cleaning. So for the hand wash, you should wash your hands for at least 20 seconds. So you need a timer. You could, it's a common saying that we could sing the happy birthday song from the beginning to the end. And then for that period of time, you would have been said to have washed your hands appropriately. Wet your hands with soap and water, and then we have the steps for hand washing. So you rub the palms all in between the fingers, the back of the palm, and then you do that within 20 seconds and rinse properly. So risk communication for COVID-19. This is part of what we do and what we need to do, even as individuals, not necessarily healthcare workers. Because if we get information on social media about COVID-19 and we're not sure, we have not verified that information and we spread it, we are also not doing justice to spreading of rumors or misconceptions about COVID-19. So risk communication, we have to ensure that we give timely information and we get everybody involved, including those in our communities where we have community sensitizations, and they have to be timely. You show empathy to them, you show respect, care, humor, humility, and truthfulness. And then we come down to their level, you give them sensitizations in their local languages, you do proper community entry so that you're accepted, and really ask questions about COVID-19 from people generally from the populace is, how likely am I to contract COVID-19? The general rule is to observe the general preventive measures because everybody is likely to contract COVID-19, irrespective of whether you're an elderly person or not. Of course, the elderly person and the persons with other debilitating illness are more at risk of getting the severe illness. But a lot of people, especially in our country where about 50% of the population are less than 18 years old, a lot of people have come into contact with the virus without exhibiting symptoms. Are there any medicines that can prevent or cure COVID-19? For now, no. We just have medications to treat the symptoms as they arise. And then the how long is the incubation period? As in, this means the symptoms, when do they develop? The incubation period is within 1 to 14 days from the time you come in contact with the person that has the virus or from time you contract the virus. But commonly, symptoms begin to develop around 5 days. So how long does the virus survive on surfaces? We have, depending on the kind of surface, 72 hours, but a lot of research is still ongoing on this. So can I catch COVID-19 from feces? Yes, it has been tested. The virus has been tested in feces, but it hasn't been documented that there is fecal-oral transmission. That means you can't get it from touching infected feces and then contaminated into your food or through your hands into your system. Then can I catch COVID-19 from my pets or other animals? This is yes. Because your pets, there are some pets like dogs and cats that also been tested positive for COVID-19. What does it mean to self-isolate? Self-isolate is, this is done by persons who have COVID-19 symptoms to avoid them infecting others in the community. So this is also one of the ways to reduce community transmission. So
okay, thank you, Dr. Salamatu. Thank you for wrapping up. You were right on time. Your presentation basically just set the platform for our next engagement. So I particularly, started to think, all of the times that Kaduna State, put in very strong measures around border control. My thinking, much later was why was this really important? And I now, with the community transmission, I begin to think that, they probably had that foresight and could see that, look, if this is not properly managed in terms of reducing contacts from people traveling, there's a likelihood that there could be an explosion within the state. I mean, looking at the fact that there are two core, in terms of the political leadership, the two core experts, the deputy governor was a medical practitioner herself, as well as the honorable commissioner for health. I think these are very pragmatic steps that have been taken. But I think it will be interesting to hear from the honorable commissioner for health herself in terms of how did they see this coming? I mean, in terms of how the committee, how prepared are they? I feel that some of the border control measures were in anticipation of a wider implication, around leading to the community transmission. So, what has prompted some of these measures? Now that the borders have been open, and people are happy to reunite with their families, how are they beginning to position, families, to particularly around empowering them with the necessary knowledge that they need, as well as also preparing the health system in terms of responding to a possible increase in the number of COVID-19 cases. Honorable Commissioner, please, you have the floor, ma'am. Thank you.
Okay. Good afternoon, everyone. Good afternoon, panelists, fellow panelists. Thank you for having me. It's quite interesting to listen to the previous presentations that have come in. I have a few slides. They're not totally tailored to what we did, but just around the community transmission, and I'll share them as we go on. Our first index case, came 1 month after we had started, about 1 month after we started preparing for it. If you recall, on the 27th of February, there was an announcement that Nigeria had recorded its index case. On the 28th, the state constituted the Emergency Operations Committee, which first started actually as a rapid response team and transformed into the EOC following the guidelines issued by NCDC. And the purpose of that was to make sure that we were getting ready, so to speak, knowing that Kaduna is a state that has a lot of travelers. There's daily flights from Lagos at that time. Soon after, we started getting cases in Abuja. And as you know, the train station transports about an average of about 5,000 people every day, either way. So we knew that we were just sitting on, it was just a matter of time. We did institute some measures. For example, we did the point of entry, the motor parks. We tried to monitor people coming in. And before the national lockdown was instituted, the state government asked for instituted restriction on movement. This was preceded just about the week before by the northern governors who closed all schools, considering that you have large congregations of people in schools. So all schools were closed at the first instance for 1 month. Soon after that, the Kaduna state government instituted some restriction in movements. Staff, junior staff were all asked to stay at home, only essential workers and high-level officials. A few days later, less than a week, the quarantine order was promulgated, and it was pronounced that Kaduna was under quarantine, which was on the 26th of March. A couple of days later, we recorded our index case. So what we were doing was following the time-honored, some of the presentation has pulled out what we should do, the guidance from NCDC, and on case management, on risk communication, which was what we were implementing. We went on till about almost 3-4 weeks later. We had the pronouncement about the Almajiri. All Almajiri should be repatriated as agreed by the Northern Governors Forum. And we had an influx of Almajiri from Kano, which out of the 157 that came into the state, 67 of them tested positive for COVID. So that marked the beginning of the spike of our cases. Maybe I'll share a few slides right now. So if you look on the screen now, it just shows you an overview of where we are at. There's a map to that should be right to my right, which shows the spread of the disease. We have about 11 LGAs that are affected, total of about 513 cases, 14 deaths, 1 death among a health worker. And if you look at the trend in the cases, if you look at the weeks, you can see from week 17, we had 6, and then we jumped to 70. And then it's been a bit of a rise from then on. And you can see in the lower cumulative cases how far we've gone. The next slide is just talking to us, just giving us a proper overview, is the age distribution of what we have. And at the bottom, you have the cases per LG. And what you'll note is that the preponderance of the urban LGs is where we have the cases. And then you look at the sex distribution and all that. So as we went on, when we started having the spike, initially all our cases were accounted for by people that had traveled and their contacts. Then we started getting some of the cases that we couldn't really explain, although those were not such a large number. And in preparation for what we anticipated would happen, mainly, as you know, the lockdown was prolonged in Kaduna State. We had a total of 75 days under lockdown, and all the neighboring states we had, Kano, Katsina, Zamfara, actually didn't have any lockdown. And so at the border areas where we have people that belong to 2 communities on either side, we were having a lot of movements. And so we decided to look at what are the strategies that we would like to do, of course, to stop community transmission. So we looked at the community standard case definition and revised it. And then we started testing at the communities and doing lab tests of all cases that met criteria. We had a lot of community engagement and sensitization. We did some active case searching around the wards of all the places where we had cases. And then, of course, the very infamous restriction, interstate travel restriction. I'm sure you've seen a lot of government officials, including His Excellency and Her Excellency, at border patrol. But that didn't really help so much. So for the period that you had senior people at the borders, there would be minimal movement. But unfortunately, when we left just the security agencies to enforce that, this didn't happen. So people were moving in and out in the evenings, and sometimes with collusion from the communities who felt that they were being deprived of some economic activities. So what did we try to do? We, of course, continue to sensitize the communities about what they needed to do. We enacted the enforcement of compulsory use of face masks as the guidance changed. One of our presenters alluded to the fact that in the beginning, there was no guidance about wearing masks. But as the guidance changed, we went into it and we tried to enforce it, try to enforce social or physical distancing, which is more appropriate, and then really try to engage the communities through all means so that we could get their buy-in in keeping some of these measures. And then we acquired a mobile testing truck, which we've been going to the communities, especially around the borders, to see what, take samples of people around there to really establish. And what we found there was about a 15% rate of the tested. Of course, the testing was voluntary. We did some counseling. And of course, if there was any positive test, then we do testing around their contact. And then we did some active case search by going house to house, and we covered about 50,000 households to see that we could pick up people that may or may not have symptoms and test them. The next slide shows you one of the strategies that we thought of launching a campaign called Forward to get people behind, what we were doing. The pressure, of course, everywhere world over is between lives and livelihoods. We had been on quarantine for 75 days. Although we were seeing an uptick in cases, we felt that we had done some preparation. So we have 3 isolation centers. We have a new isolation center being built, which should be completed by the end of this month. Medium to long term, we're thinking of putting isolation units in every general hospital, which is every local government. And we're streamlining our COVID response right now into the routine services. Because now that we have community transmission, we will increasingly rely on the frontline health workers at the PHCs to be able to suspect, pick up, and link this strategy of testing, of tracing contacts, and isolating, and trying to minimize spread. This campaign, as you can see, says forward face mask is our shield, stop the spread. O is for observe physical distance, keeping at least 6 feet between others. Respiratory hygiene is R, cough into tissue or bent elbow. W, wash your hands with soap and running water, if not available, hand sanitizer. Avoid large gatherings, remain indoors, exercise, keep fit and healthy. And then the last one is diet. I know earlier presentation alluded to all these things, but we know that if your immune system is strong, you're able to fight COVID. Coupled with that, we had some stakeholder engagement about relaxing some of these measures. This is just 2 weeks old. This is being assessed. And it was made clear that if we slide back, or if we have an upsurge of cases and it seems to overwhelm our system, we may have to institute lockdown measures again to see what will happen. So the next few slides is just to show us one of the local governments that has a high number of cases, which is Zaria. We looked at, when we did the data, we looked at the primary case came from someone that had contact, had evidence of travel, McAfee's and LGA that is close to Katsina, and part of it to Kano, so we had evidence of travel. And although we did a lot of things, you all know, and it was alluded to, the general populace really have some issues about COVID. It's too, I would call them a little bit of an extreme or two extremes. There's the group that really understand and know what it is about and are really scared and are keeping to the measures. And there's a group that thinks we're all just making money from this. Unfortunately, it seems a large proportion of people think that. So the skepticism, and especially we noticed that around Zaria LG. And from the data, what we saw is for about the 10 million population, we're likely to get infectivity rate, we're likely to get 534% during this reporting period. And if you remember my first slide, we are already at 513. So the data is telling us, is being corroborated by the number of cases that we have. Our testing strategy is to cover all wards, at least try and get 100 samples in the first instance. so that we can properly map out what exactly is the burden in each of these wards. And it will help us better target our strategy. So for example, if we know a particular area has high transmission rate, we could attempt to do the lockdown around that area. I say attempt because, you know, we have fluid borders, especially around wards, and it needs real enforcement. But it helps you to localize, it helps you to target even your risk communication, and it helps you to isolate that community, at least reduce the numbers coming out from it. What we saw was that between 2 to 9 people were infected from each case, and we found that contact tracing was very important for us to be able to do that. So what we found was that 70% in that community, actually within city, had no history of travel and no history of contacts with probable cases. 1 or 2 of them did, but we found clusters, family clusters. So one of the families that we tested actually had 10 members of the family turn positive. And this is just a graph showing us the number of cases and how many they infected. This is showing us the chain of transmission. And like I mentioned, the challenges, you know, how to stop people from moving about. The skepticism in some places, and the denial of some of the positive cases. And we had that particularly in Zaria. People were counsel tested. When the results came out, they would simply just disappear, sort of switch off their phones, refuse to be picked up. And in 1 or 2 cases, we had to actually employ law enforcement to get them, you know, to comply. And I think what I would just say in conclusion, that is that, you know, it's been established that we do have community transmission now, especially in some of our communities in the LGAs. And we must have some appropriate testing strategies to identify such communities and target our response to isolate, treat, aggressively trace contacts to prevent further spread. And then the last one is that you really have to have the people behind you. A lot of it is personal responsibility. We tell you what to do, cough into a bent elbow. If someone doesn't do it, he's likely to spread it. Wear a mask, which is compulsory. How many people do you track that have masks or they don't have masks? And how many people can you enforce? You have a population of about 10 million. Law enforcement, we know, is stretched, and you have that skepticism. So that's the most important thing, I think, to limit the community spread is really to get the community to understand. I will stop there. So that's all with the slides. But I think what I will add to what we try to do, I don't know if I'm into my 10 minutes or past it, but I think what we've tried to do in Kaduna is follow the science and contextualize it. We all know the science says test, treat, isolate, and you know, take the guidance that we're all working with. But we also have to look at reality. We have a large population of people that really earn daily living. And 75 days being indoors has taken quite a toll. Although the state government has given out palliatives to the most vulnerable during the lockdown, we all know that the longer it takes, the more vulnerable people are going to be. So what the focus of what we're doing now is how do we enforce those guidelines? So if you have a shop, for instance, there are guidelines on what you should follow, how you must have all public places and places of business that have applied and complied with the must have hand washing facilities, You must be able to screen people. You must be able to map out and make sure that physical distancing is being observed. And we're constituting monitoring teams. We're reviewing weekly to see the progress. And the PTF has raised this concern all over the country that we're not really complying with the measures. And that, like one of the earlier presenters said, we haven't seen the peak. So we may have to reinstitute those measures again. And the key to doing that is really carrying the people along. So thank you very much for the opportunity. And I will stop there. Thank you.
Thank you very much, Amina. I think I believe that a lot of people have gotten some of their questions answered. There were lots of concerns around why Kaduna was, so to say, being aggressive, because amongst all other northern states, Kaduna was one state that put in place very stringent measures in order to control the possible spread of the COVID-19 virus. But I have a question for you, Dr. Amina. So
Yes.
Across the northern states, there were recorded cases of death due to unknown causes. So was that something that was experienced in Kaduna as well? And if it was there any linkage to COVID-19? Again, we've gotten some explanation around some of the sudden deaths in other states, particularly in Kano, in Jigawa. I think it was reported also in Yobe at some point and all that. So, I mean, how are you tracking that in terms of your surveillance system? I know that there's the DHIS tool, which has been effectively used across the state. How are you using that to track increase in number of cases vis-a-vis prior to the COVID-19, to be able to say, okay, there's a spike, and this spike will be due to possible compromise in the system that has led to increased deaths and all of that. Is that something that you've experienced in Kaduna? Thank you.
Thank you for that question. I think, of course, when there was a lot of attention around Kano and Katsina about the sudden deaths or the spike in deaths, what we tried to learn from that was to do some community engagement around, reporting deaths through the traditional system and to the LGA system. We revised the burial protocols that were released from NCDC and engaged the community and religious leaders to, first of all, to treat, deaths to report them, first of all. And the LGA teams, the DSNO and others involved, to do some verbal autopsy around that, so that if there was an indication that this was suspicious, so to speak, then we would do some testing around that. Also, we tried to engage most of the private facilities about protocols of management of COVID, and also protocols around people that died, that were ill, so that we had a tab. We should have a tab on the numbers and the types of conditions people came in and died with. It may interest you to know that of the 15 deaths that we had, actually just one recently, last 2 days ago, 2 days ago, were two of them were actually COVID confirmed cases. And they were under treatment. Of course, they were elderly and they had underlying conditions. But all the others actually were diagnosed post-mortem because they came in, maybe they had been around or they had been at home, not engaging. And when they started having difficulty in breathing, they came, and within 6 to 8 hours, they were already passed. But we haven't noticed from this community surveillance that we're doing of a spike in deaths. And we're keeping tabs on that. because we know that as we're moving into community transmission, this is likely to happen if people are not being aggressively followed up and removed from the communities and treated while they test positive. So part of the strategy of going to every ward actually is for us to establish if there's any COVID cases, and also to greater engage around what the risk communication and how we should manage it. Thank you.
Thank you very much. Thank you. Dr. Hakim, I was just thinking, is there, you have an association of chemical pathologists. This question is also targeted at Dr. Medu as well, and also an association of microbiologists, and I'm sure you have state chapters everywhere. In terms of how you're working and sharing some of your expertise knowledge, with state government and helping to drive state government strategies and informing a lot of their strategies. How are you working with the state government? If you're not already working with them, what plans do you have? In terms of also helping them to improve, and enhance their strategy, particularly as we go into the community transmission phase.
Okay, thank you very much.
Do you want to go first?
Yeah, okay. Thank you very much for that question. And people always get confused regarding some of our designations. Yes, I'm a chemical pathologist. My colleague is a clinical microbiologist, but we are all pathologists. And there are actually four aspects. There are the anatomical pathologists, those that conduct autopsies, not verbal autopsies. I'm talking about the real show here. And there are the hematologists. Okay, and I'm the current secretary of the College of Nigerian Pathologists, and we've reached out to the NCDC and telling them that we are available for to partner with them, collaborate with them, provide expertise. Some of our members, actually I can speak of Oyo State. Dr. Fowotade is the laboratory lead in Oyo State. She's a clinical microbiologist. And I can tell you she has been away from her family. I don't think she has had contact with her family for the past 3 months, because if you are in the front line where you wear these hazmat suits, you can't just go back home. You have to stay maybe away in a hotel while you go back to work, So it's very tedious. My colleagues are all over the country, those in Kano, in Kaduna and all that. But I will tell you that pathologists are few and far between. But on the register, we are like less than 500 in the country. And so, but we are also looking at the fact that, we'll be talking about frontline workers, I think community transmission is not telling us that the people in the community are now the ones in the front line. We are now in we are the last resort. We must not fail. So we are preparing we are preparing to receive and to care, we are preparing to receive patients, COVID or non-COVID, at our tertiary healthcare facilities where many of us practice. And so that we are not overwhelmed. What is working for us in Nigeria, somehow, whether by divine intervention or I don't know, is that the system has not been overwhelmed, unlike the way it happened in Italy, in Spain, in the UK, and in the US, whereby more people get sick that they can be contained in the health facilities. And you tend to have everything just goes haywire. And that is why, we must commend Lagos State, Kaduna State, and other states that are like, how will I say it now? They are like shining examples of how to practice public health, because we don't need to get people, we don't need to get to that stage whereby public health will fail and the hospitals will be overwhelmed and all that. Let me allow my colleague to throw some insight into all that.
Dr. Nebua?
Oh, yeah, so I agree totally with what Dr. Olawal has said. The clinical microbiologists have been in the front line, and eager to contribute even more to the current fight against COVID-19 in Nigeria.
Thank you very much, Dr. Midugu. I think this question, I have a question for Dr. Midugu. Will this be? I think we've heard many times that the tropical climate in Africa is really helping in stemming the spread of the COVID-19 virus. So now we're going into the rainy season. Are there possibilities, because we're going to be experiencing lower temperatures now, are there possibilities that we could experience by way of environmental factors, that we could start to experience an increase and probably more susceptibility amongst individuals for COVID-19?
Okay, so theoretically speaking, yes. So that has always been the theory, but COVID-19 has proven that temperatures may not really play a major role when it comes to spread of viral infections. That being said, the rainy season, the place is humid. So in humid environments, you tend to have water droplets in the air, so that when you cough, a lot of it still remains in the air. When it's cold, we have the natural defenses of the body, such as your nostrils, right? You know that there are hairs in the nostrils. There are even smaller ones. Those are all protective mechanisms in your body. So they slow down when the environment is cold. Even the white blood cells, those are the fighters of the body. Their activity is also lower when it is cold. That is why during cold seasons, we tend to have more of the cold and catarrh. It's not because the virus is more at that time, it's because our innate immunity, which is these things I've listed, are sort of slower, and then the humid environment gives a very conducive atmosphere for the virus to just relax and cause infection. We may not necessarily have an increase. Now, these tests that we're seeing are not necessarily reflective of what is going on in the community. It is also reflective of how much testing is going on. You remember that at the time there were only 2 labs in Nigeria, and now there are some 20-something labs in Nigeria. Now we've reached 10,000 tests. So the more you test, the more likely it is that you will pick. So when you see these statistics, always know that it's also related to the amount of testing you've done. We know that there are some countries that have reported almost nothing, and it is because they've not done much when it comes to testing. So, yeah.
I have a question here from David Kige. David Kige is based out in the United Kingdom. So I think this question might be directed to the Honorable Commissioner in Kaduna. The question says, since we're doing targeted testing, does anyone know the positivity rates nationally by states, e.g. Kaduna and by...
Yeah, thank you for that question. We're just, we're in the process of looking at our own data. We've only just started doing this community testing in the last week, coming to 2 weeks now. So as we're moving, we're looking at the data, we're looking at the numbers. And the more you test, the more accurate your predictions would be, actually. If I'm just testing 300 and I get 50 positive, it may look like a higher rate as opposed to when I test 1,000 and I just get 50. So the more we look at the data, the more we can draw inferences from it. So what we're doing is trying to look at the data. I don't know if this is being done. I think it's being done by NCDC. I don't have all the details on that, and I'm sure other states are also monitoring and tracking. Lagos is doing a lot of tests, so you can see that when they get quite a number of positive cases, sometimes 100, sometimes more than that. So the more you test, we know that part of the issue with the public is that they see our cases rising and they think we've done with all the things we've done, but part of it is a function of the strategy we're employing. So the first thing we did was to test contacts, all contacts now, and then we do the community communities where we have high risk, and therefore the yield will be bigger. So as we're going to our silent LGAs or silent wards where we didn't record cases, I think that would give us a better idea in those areas whether we're having lots of cases or they're truly silent, they don't have a lot of infections. I hope I answered that question.
Fantastic response. So, talking to the pathologist in the house. I remember talking to a professor colleague based in the US, and he was talking about non-invasive postmortem and how that can help, particularly around in areas where it could be seen to be conflicting with religious or cultural, beliefs. So how can that help? I know that is something, again, that could have helped in cases where, in places like Kano and Jigawa and Yobe and many other states, where they've recorded, cases of deaths due to unknown causes. How are we helping to put in place a framework for non-invasive, postmortem that could help, state governments, to be able to take more proactive intervention, around how besides COVID-19 and any other infectious diseases.
Okay.
Between Dr. Hakim and
let me just delve into your answer. I think the question is, why are we not doing postmortems? Non-invasive postmortem, I've been trying to wrap my head around that. A postmortem is a postmortem. But sadly, a postmortem facility that can accommodate a COVID-19 patient, we've not seen such infrastructure, because it's not just about, these particular labs. Why are we not doing COVID-19 testing, molecular testing in all labs, in all teaching hospitals? It's because there are specific requirements. It must be a negative pressure level 3, safety level, level 3. That's for a lab. Now, for an autopsy of COVID-19, because of the fact that, especially, you need to, you need to open the lungs, you need to work with the lungs. You also need what you call a negative pressure autopsy facility, which currently, Lagos has a very good, Lagos State lawsuit. I think they have a forensic pathologist, Professor Bafunwa, was able to design a very good autopsy suit. But even he himself, surrendered that his facility, they won't be able to handle autopsy for COVID-19 cases there. That's just the truth. However, that doesn't preclude the country from, not going into autopsy, because autopsy will allow us to know whether some of the patients, some of the people that have died, are not even, they may not have died because of COVID. This is a little what I know. I won't be able to comment on the non-invasive autopsy. Maybe what you're trying to talk about is a minimal autopsy. But I think the government strategy should look at, for instance, minimal autopsies, so that maybe they can avoid, the lungs. However, how we do it, we need a strategy. I'm happy we have a government person with us. We need to start looking at these autopsies. Verbal autopsies, I've abandoned hundreds of years ago. Nobody does that. So we're surprised to hear about when people started dying in Kano, and they were saying, in fact, I think it was from the mortuary sites attendants. You know what it takes to dig up. Maybe they used to bury maybe 10 people, 20 people in a day. They started burying 200, and the burial is manual. You have to dig it manually. So you have to cry out. So I think that's where people started knowing that something was going on in Kano there. So that's the bit I can contribute.
Thank you very much. Any word from Dr. Medugo?
Okay, yes. I know something that has positively impacted diagnostics, I think, in Abuja is the fact that even for diseased people that are suspected, still samples are collected because these are swabs, right? So even for diseased people, we can still collect swabs and still process, and that will guide us towards burial practices, contact tracing, and all that. So as Dr. Lawal said, we can do really minimal autopsy, although the facilities really do not make people safe when they do it, and that could include aspiration of lung fluid for the testing.
Okay, thank you very much. There's a question from Mamza Wali. I think Dr. Medugo, you might want to take this. Do I have to wear a face mask under a face shield? So there's this very common face shield now, this very fancy face shield people wear all over the place. So he's saying, can he wear, is there a need for him to still wear a face mask under the shield?
Absolutely. They serve totally different purposes. So the face mask protects the nose and the mouth, while the face shield protects the eyes. So when people are talking or coughing, they release small droplets into the air, which can get into the eyes. So the function of the face shield is to prevent those droplets from entering the mucous membranes of the eyes. So if you want to use the face shield, please use a mask also.
Okay, fantastic. Just a few more questions, and then we'll be wrapping up. I think we've spent quite some time. A question from Abdulaziz Abdullahi. Does government at state level, including Kaduna State government, prepare risk analysis for disease outbreak in case before Dr. Amina, I think that question will be for you. Was a risk analysis conducted? This question was asked prior to this presentation. I want to believe that your presentation should have responded to this, or maybe you want to, the risk analysis carried out before easing down the lockdown?
Yes, there was a risk analysis was done. Also, a lot of consultation was done. I think there's a bit of a misunderstanding on actually what the easing of the lockdown. The lockdown, the easing of the lockdown measures, let me put it this way, it has not been lifted. There are guidelines to be followed. So it's not automatic that because we said there can be prayers in mosques and churches, it's not automatic that each mosque or church can just open up and start having services. There is a set criteria that you must follow. There's an inspection that must be done, and it should be allowed. And we have made it clear that if this is violated in any way, then the privileges, so to speak, are revoked. Same thing with the shops. You can see the markets are still not open. We're still operating the temporary markets, and this is the physical distancing is carried out there. Make sure that anybody that is going in, there's an enforced use of masks. So it's not automatic, so to speak. The interstate travel ban was announced by the federal government, but you can see that most people are observing it in breach. So we extensively debated it, and we weighed the science. Of course, if you look at the science purely, we shouldn't have opened up. But if you also look at the reality on ground, the fact that people were really in a bind socioeconomically, people were suffering, and also the fact that the consultations, the various stakeholders actually said they would abide by this conditions set. And also, if you even look at the lockdown in Kaduna, it wasn't a full lockdown. There was still some economic activities. Construction was actually going on. because it was adjudged to be low risk, and it was monitored to make sure that people were not congregating. So we did, and we're looking at the data, we're looking at the reports, and we have the backing of the government that says if we feel that this is something that's getting out of hand, the lockdown and the quarantine will be reinstituted. We hope it won't get to that point, but
okay, thank you.
that's the only.
We hope not. We hope not. Kaduna is a gateway, so we need Kaduna opened. So
but we need to be alive too to be able to.
So this question will be more for
manage.
a virologist, but absolutely. So this question, the next question is probably for a virologist, but I think our colleagues from the microbiology can respond to it. The question is, I'm a lot concerned with symptoms as well. You know, that most cases in Nigeria need the ventilators government invested in. Are symptoms different in Africa? So I think the question is twofold. So one question is the possibility of a mutation, which could make it more virulent, which could make it more dangerous, or and also, could that be the reason why the cases in Africa is different? You know, particularly the fact that we didn't have a lot of people, relying on life-saving devices like the oxygen machines. So, Dr. Midugu, can you please respond to that, please?
Okay, yeah, sure. So by virtue of the fact that it is an RNA virus, it is indeed prone to mutation. What it means is that it's like usually people have two legs, but in this case, RNA viruses have one leg, they have only one. So they tend to mutate really fast. However, the mutations for viruses usually makes them less lethal infections. Why? Because when viruses cause infections and they cause the people to die, they're buried with the persons, right? So these ones are unsuccessful viruses. What have you done? You've killed the house, you've occupied the house and you've killed the owner and you're buried with the owner. So what viruses try to do is become less lethal so that they are able to survive more and spread more in the environment. Now, yes, there are mutations that have occurred with the coronavirus, the SARS-CoV-2, and different people have assessed it in different ways. Some of them have assessed it based on how lethal it is, and so you have the very lethal coronavirus, you have the non-lethal one, and then you have the moderately lethal one. But then again, as I said, research, one research will come out, another one comes out to debunk that. Then so that has been debunked by some people. Some people are still working with that. And then others are also using lineages to classify it. So I wouldn't say that it is becoming more lethal, no. I think what is probably happening, and this is what I think, what is probably happening in Africa is that we have less ventilators, we probably have less manpower to also use the ventilators. Now, even in the United States, where they thought they needed ventilators, research has shown that in many cases where they ventilated people, they didn't need to ventilate people because ventilation did not even improve outcomes. So across the world, Europe and the United States, there is less reliance on ventilation. So now that the disease has come to us in Africa, we've realized that there are other means of sustaining the life of the patient without actually ventilating the patient. So those three things have played together to give us the kind of picture we're seeing now.
I had to upgrade associate professor now, I believe. Olalekan Uthman. I'm asking him to start his video. He's joining us from the UK, and I hope he can hear me. Just give us, he has been with us, just give us some insight how the UK is faring. What can we learn from the UK at this stage? A lot of people have, have had COVID, people have survived, people have, some have sadly also passed on. Professor Olaleko Uthman.
Okay. Hello.
We are with you.
Okay. Hi. So thank you. Good evening. So this is a surprise package for me, Dr. Akim. So, and thanks for the opportunity to say one or two things about the COVID in the UK. So starting from this week, I think we are sort of being relaxing things now. And as you've mentioned before, and other panelists, it's not that the science is supporting that it should be relaxed now, but there's huge pressure on the government to relax things because of the economy is being damaged, and like even the 2-meter distancing, they are asking them to relax it to 1-meter rule because some construction work is not being able to be done. So if they relax it to 1 meter, it's going to sort of increase the more activities can be done. And there are a lot of trials that are being undertaken in the UK to see different interventions that can be used to sort of treat severe disease. And luckily we found something about this, the dexamethasone, which is the first treatment that shows that it can sort of preserve life, it can sort of reduce overall mortality. So there's some other area that we are working on and that I think is very relevant to us in Nigeria too, is they've started on cohorts to start following the patient that survived now, because we need to see what's going to come on later on in terms of the complication that they will have after even surviving. We may think that we're out of water now, but we need to follow some of these patients up. And so that's another area that I think is relevant for us to sort of look into in Nigeria. Then the test and trace application is being tried in the UK here. I think they've shut it down again now. So it's another area that I think we need to sort of do in Nigeria now to sort of see how can we use some of these digital heads to sort of monitor patient and sort of reduce the burden on health worker and how to sort of test and trace, and so that it's not going to be test and trace that's being done now. So that's another area that I think we should look into. So then we are doing some work with the Public Health England here using some of this machine learning and artificial intelligence. So we have pool of data now that we want to see what are the important risk factors that we can use to predict the severity of some of these patients that come down with severe condition. We know some of them, there are common sense signs that obesity, overweight have been some key factors that have been identified, but we are doing more work on genetics. And in fact, I'm working with a colleague in Kano to start to do some work in terms of some form of this kind of work so that we be able to predict patients that can come down with complications so that we have a more proactive care for them. So, I mean, those are the things that I think is applicable to us now.
Okay, thank you so much. I'm happy that you've enriched this discourse. We can see all over the world people are sharing knowledge and experiences, and even China. That's the whole thing started. It's not yet. It has not ended in China yet, and we need all the information we can get. We need to separate the information from the misinformation, and we need to also make sure that we have what you call evidence-based information, so that we can exit this COVID crisis faster. I think we have another person quickly joining us. There's Hawa. Hawa Abdullahi has been with us and she has asked questions. I hope she's with us, and I think I'm trying to unmute her microphone, and if she could just make her contribution briefly, because we've already spent about 2 hours on this in this session, so that we can quickly round up. I hope otherwise, are you with us? Many people are new to this Zoom.
Yes,
please.
I am.
Okay,
Good
fine.
evening,
All right. We are listening to you.
Yes, I had asked earlier, in view of this pandemic that we're into, quite a number of other health interventions have been on the low ebb, or you have a case of conditions like malaria being quite fatal, and you may have quite a number of fatality from malaria. What are we like kind of doing to integrate malaria control among other interventions along with the COVID-19 pandemic response? This is my question.
Okay, thank you very much. Yes, we need, malaria is killing people. Somehow, I think we are going to organize, we are going to look into another session to look at how to integrate, what has been there. Malaria is still killing people, and everybody's talking COVID now, so they seem to be neglecting the tuberculosis, the malaria, and the other infectious diseases. I can see Dr. Amina is not with us, so I don't want to answer out of context, but I think it's a good question, a very good one. We have to look at this course cannot end. We look at, especially in our environment, infectious diseases are a problem. So we have to look at programs. Government needs to listen and look at how we can, even after this COVID, COVID not be here forever. We must learn to integrate COVID, HIV, malaria, and all the things that, all the infectious diseases that we are dealing with. Lassa fever is still there killing people. Nobody's talking Lassa, but Lassa is still there. It's still there. It's not yet. So, but thank you very much for the question. I think we'll look at addressing that in probably another session that will do justice to it. All right. Permit me to thank everyone that has come. I can see Dr. Giwa has not been able to come back. Okay. I see Dr. Giwa is on. He doesn't carry last. If you can hear me, Dr. Giwa, we are just about rounding up. But let me just quickly thank all people. Dr. Giwa will round up the thanking. The College of Nigerian Pathologists and the Secretary also contributed to this program, and we're happy to have the Commissioner for Health, all our resource persons, including myself. I should thank myself too for making this a reality. I'm happy for those all those that join us around the world. I've seen people from the UK. I've seen people. This video is going to be cleaned, and we're going to have a link to it via YouTube, where those that may have missed it can watch, and even those of us that are watching may want to look at it again, and we can share it to all our loved ones. We hope it will help in some way in controlling COVID-19. Over to you, Dr. Giwa, for the final bye-bye. Okay, it seems Dr. Giwa is still having some challenges there.
Thank you very much. He's telling me that he was down to.
Yeah, where would you continue?
So, can you hear me?
Yes. We can hear you.
So I guess my internet was telling me that we should be running. Yes. So I want to especially thank the Honorable Commissioner for Health for Kaduna State. It was a very tight. I know there are other commitments. I want to use the opportunity of this platform. We were declared polio-free yesterday by the WHO African region after fully and duly completing and the assessment. So congratulations to every near future will also be the COVID-19. Bula Magarba from the National Primary Healthcare was earlier scheduled to be on this panel. Unfortunately, because of the other activities, national engagements, it was unavailable. Thank you, Dr. Amina. I know that we took a lot of your time, but I think this is worthwhile. This has given a lot of education and information to a lot of people out there. To the lead speaker, Dr. Akim Lawal, fantastic work putting together this webinar. To Dr. Nibwa Meduku, my sister from Borno, thank you very much also for making this a success. And to my sister Salamatu Belgore, thank you also for all of the efforts put into putting together your presentations and putting it out there. We believe that this will add a lot of value to the ongoing efforts in the management of the community transmission of COVID-19. Thank you very much. All the participants that spend their time to listen to this conversation. For those that sent in questions, thank you very much. We hope that some of your questions were answered and that you've gotten something that you can take back for your loved ones and your families. We thank you. We thank everyone. We thank all the panelists once more, and we wish everyone a happy weekend. Thank you very much.
Okay, so bye-bye, everybody. I'm ending the session now.
Bye.
Thank you very much.
All right.
Thank you. Bye-bye.
Right.
Okay.
Thank you.
All right. Bye-bye. Bye-bye.